This conference will now be recorded.
There we go. And we will be uploading a copy of the recording as well as a copy of the slides to our website, which is shpllc.com/webinars. It should be up this afternoon, weather permitting, that we don't lose internet connectivity. So with all of that, Mike, let's get started.
Right. Thanks, Aaron. Hey, appreciate it. It's been a few weeks. We sort of had a little lull in activity around all this, but with the new bill that got passed last week, there was a lot in there. We'd been sort of saying that there wasn't really a whole lot in it directly impacting y'all, and I guess that was a little bit of an understatement because there are a few things that I think we need to look into today. All right, next slide, Aaron. All right, so the first thing, we kind of have this kind of broken down into 4 or 5 kind of major hunks of what is in there. One of them, it was that a funding of a reopening of the health exchange has been in the works for a while now, and it went live 2/15 to 5/15. And what's going on in there wasn't just that it was reopened, but it was also an increase of the subsidies, kind of in a couple of hunks. One is it had always previously cut off at 400% of federal poverty level. And so now there are subsidies for people that make more than that. And I'll show you examples of that in just a second. And then an increasing of subsidies for folks that are underneath that. And so now, whereas it used to be that the premium couldn't be more than 9 and 9.5% of income, now it's lowered to 8.5%. And the credits got increased with that. So go to that next slide. Here's an example of some averages that under the prior health exchange rules, somebody making 15,000, previously the law would allow them $26 premium to flow through to being out of their money. That now it's at zero. 30,000 went from 195 to 85. And then I won't read them to you, and they get kind of less beneficial as you move up the income scale there. But the point is for folks about 45,000 or less, individually, it's taken off a third to more than a half to all of the premium that was going to be unsubsidized to a member to make it more attractive for somebody to want to come back to the health exchange during this round. Click to that next slide. And in looking at ones that are above 400%, it kind of makes it to where it's kind of doable. Like look at the 45-year-old individual at 470% of federal poverty level. Okay, they get $90 out of an average of 515 off the prior law. So that's a little under a 20% reduction. 60-year-old couple, because the health exchange unsubsidized premiums are age-based, somebody at 435% of federal poverty level, it gets pretty attractive for them. That is that's a nearly three quarters drop on the premium that they can be charged, or will be the unsubsidized portion that they would have under currently at $531 versus $1,900 in Georgia. And so that's pretty significant. And then a family of 4 making 120,000, which is 458% of federal poverty. So it's a good amount of money, but now their max premium is $850 under the current law. And so that's a reduction again in that instance of about almost 30%. So go to that next slide. Well, and I guess before we get to this, for those of you, hospitals on the phone, if you remember back to the 2000, whatever, 5, 6 years ago, 6, 8 years ago, when the health exchange started, we had all this thought about, well, let's take the self-pay population and route them over to, financial counselors and other people that can hook them up to go talk through what their opportunities are to get coverage through the exchange. If we would have done that then, we should be willing to do that even more now, because if you're one of the hospitals, and you go back about 6 years, your self-pay dipped when the health exchange started. And then as it slowly started to erode over the last 4 years, the uninsured population has been bouncing up by about 10% a year since then, such that the last data that's out is 2019. It's jumped back to 10.9% in the country, which is basically where it was 6 years ago. And so now the exchange offers a much more enhanced reduction of premium than it used to. And whether or not we like the type of benefit plan designs that are out there for a hospital emergency room, it now, moving off of self-pay dollars, which is virtually nothing, to, some sort of quasi commercial paid plan is a lot better than that. And I think I missed one point from the prior slide, which was, and don't go back, was that the CBO suggests that this process is going to take 2.5 million people off of the uninsured rolls in the country. Well, that's 8, 9, 10%. And so that's not totally immaterial. If you're a hospital running 12% self-pay, it's the difference between 10 to 12, moving from 12 to 11, 12 to 10. And so that's pretty material for you. A couple other points that occurred in there, that the old clawback, that if you underestimate your income and it was higher later on, they could take back some of the subsidy. That's gone for this period of time. But one significant point is that now the exchange premium they'll cover 100% of the cost of COBRA premiums for laid off workers all the way through 9/30 of this year, which is estimated to be a couple of million people that are still in COBRA period after they lost their job back during the COVID time. So next slide. The next kind of major angle that's in this are a couple of versions of looking at Medicaid expansion. In the American Rescue Plan is a significant increase of the FMAP. The FMAP is the percentage that's used to determine what the federal match is on the Medicaid funding. And so currently, think in terms of about 70% of Medicaid dollars come from the Fed and about 30% comes from the state. And that may be off a point or two, but this increases 5 points on the FMAP, moving it up to, say, a 75-25 split, which is not just 5%. It's a 30 to 25. It's a 16% reduction of state-borne cost or state-accepted cost, and so it's pretty but only if you expand. And so it's the new offer to expand is that 5% on that, plus the old 90-10 FMAP split for the expansion population itself. And so given the fact that even in expansion states, 80% of the population was already on the plan and they're only expanding to cover the other 20, it means that the current offer from the state for the next 2 or 3 years is more than 100% of the expansion cost. And whether or not Georgia will jump on that or not, I don't know. I really haven't seen any reaction at the state level to it, but the CBO estimate of the additional funding that would be pointed at Georgia is 1.88 billion annually. So there's that, and we'll need to follow up on what the state's going to do around that, which, sidebar, it is definitely time to get the DCH folks back in front of you guys to talk about this again. Go to that next slide. The other thing that's kind of happened in this world is that, if y'all recall, we had discussions from times past about the Medicaid waivers that Georgia had applied for, and there were 2 flavors of it. One was the stateizing of the health exchange, which would move it into a state version of subsidies. So take that one and set it aside just for a second. The other one was related to the state Medicaid waiver for the Medicaid population itself, which was to get at that donut hole of the low income Medicaid kicks in at the state level at less than 40 or around 40% of federal poverty level, and covering that gap between that and 100% of federal poverty level. And in theory, that's where the health exchange picks up. And so there are 600, if y'all recall, there are 600,000 Georgians that are estimated to be in that donut hole. And the state had, under the Trump administration, had gotten approved a Medicaid waiver to address that population, but it came with some work search and some actual work requirements in there that were an ongoing documentation of that in order to maintain Medicaid coverage. The Biden administration now has unapproved that previously approved waiver, and now has moved the status back to under review, with an idea that it seems likely that the pushback is, or has been, that it's the need to remove the work requirements in the eligibility, the general eligibility limitations in there. The feds had a stated goal of trying to cover more than 50% of that population. And so it is the difference. That's that last point there, is that the state original projection was that 50,000 out of the 600,000 would obtain coverage under their current rules, or the rules that were approved previously. And under the federal goal, it's with it being half or more, it's the difference between it being a shade over 3% of the uninsured population versus 20% of the uninsured population under the, if the new administration gets a much broader definition of that and much less eligibility limitation involved in that. Kelly, anything to add to that point before I move on?
Mike, I don't think so. It'll just be interesting to see how Georgia sort of reacts to that carrot put out there for Medicaid expansion.
Yeah, I think from both perspectives, it's, again, let's set politics aside just for a second. Between both of the two, if the state were to expand Medicaid and a full version of this Medicaid waiver to go into place, it would be a significant increase in the Medicaid population, ultimately increased in cost for somebody, but for our rural providers out there, or the rural hospitals that are on the phone, and then it's going to be a significant increase to the or decrease to the self-pay populations out there, which again, for the hospitals on the phone is a very good thing. For the CSBs that are on the phone, there's obviously that line between more people getting coverage and moving into Medicaid versus other funding sources that you guys have. And so I get there's a flip side to that discussion as well. Next slide.
Hey, Mike, real quick, before we move on, I think there was a question as it relates to the health exchange plans, specifically if there's been any change in the deductibles or sort of cost sharing for beneficiaries. And presently there has not. The current plans offered on the exchange have the same plan design that they went live with on 1/1 of this year. Any changes to that wouldn't take effect until 2022.
Gotcha. But I guess in sum total of all this, again, is from a perspective of the hospitals who are out there, between all of this, between getting really involved in the health exchange and sort of, if you chose to, lobbying for the varying angles of expansion, you could be sitting on a fairly substantial reduction of the self-pay population for you guys. All right, additional Medicaid provisions, the home and community-based care will receive.
They just kind of got started. They were talking about Medicaid expansion. How that's not.
Hey,
get that downstairs. Yeah.
Hey,
I'll come back.
Got it. Okay. All right, let's move on. So there is some home and community-based care, some increased Medicaid reimbursement for a year, and then another point where states are expand Medicaid coverage for new moms up to 12 months postpartum to reduce maternal mortality rates. And so if anybody wants some additional information about that, we certainly can provide that at a later time. Okay, now those are the first two. Third whole swim lane of what was in the new bill that is probably more impactful for you guys. I have been telling you guys that I didn't really think there was a whole lot of money in there for you, and that's not true. There is another provider relief round that's in there, which is for quote unquote rural providers, but you'll see in just a second, the definition of rural seems pretty liberal to us. It's $8.5 billion earmarked for it. At the same time, though, there are $24 billion unspent from all the prior rounds. And so, and again, Kelly can jump in here too in just a second, but who knows if they're going to dump all of that in this round. But to put in context, all of the rural rounds that have occurred so far have thrown $11 billion at quote unquote rural providers. And so whether or not it's 8.5 or it's 8.5 plus some portion of 24 billion, it would appear to be a fairly material amount of money for you guys. The rural hospitals, rural practices, and to the lesser degree, the CSBs, y'all know what you got last time. And there's some pretty substantial dollars that have been tossed around thus far, and reloading that for rural providers is, helpful. One point you won't see in here is that it doesn't appear to be that any of these dollars are earmarked to urban providers. And so that's probably something that we still need to continue to lobby for. But nonetheless, those last 2 points there, what is different about this, and I think I told somebody this dead wrong the other day, is that there will be an application process for that. And so whereas most of the prior rounds, other than turning in like banking information, there wasn't anything for you guys to do, this time there's an application for it. No idea what that's going to look like, which is that last one, and no idea what the distribution methodology is going to be based on, but it's out there. I would presume it's going to be based on some statement of what you've lost, or at least a statement on your ability to continue to treat COVID patients and without having dropped any staff in the process. But we don't know that yet, and we'll listen out for it. Move to that next, hit that next slide. All right, this is what I was talking about with the definition of rural providers. So it kind of layers on different angles that I think are trying to send us a message that they're trying to be very open-ended with this. So it's either a rural area that's defined in the Social Security Act, it's a rural area under another section of it, it's another area giving the HHS secretary the ability to kind of define what they see as rural patients. It's a rural health clinic, or then it's it's people who have home health, hospice, long-term services, whose home that you're serving is located in a rural area. And then it says HHS secretary can just add in anybody they want, basically. So at the end of the day, so it seems like the idea is to be broad. And so I will say this for sure. If you are a provider that is in a designated urban area, but you are in a rural county, the definition of a county that is bannered around in this was under 500,000. So think of Savannah as a rural county potentially for this. And so, especially if you're one of a provider that's on the edge of that, even if you have been sucked into the MSA for purposes of some Medicare reporting purposes, it's still a good shot that you can be considered to be rural. So, definitely go through the application process for this. Go to that next one. So again, kind of moving out of that swim lane into a couple of others. There's some smaller dollars here, 500 million toward Department of Agriculture grants to those, municipalities, counties, nonprofits, those kind of things. But those grants can be used to cover COVID-related health expenses, those kinds of things. And so it doesn't look like those dollars are necessarily pointed toward you unless you're going to apply under the, an idea that you're going to try to increase capacity telehealth capabilities. Then the next slide, for vaccine supply, there's a whole bunch of money either pointed toward a more comprehensive testing strategy, more prevention activity, various types of vaccine distribution or more vaccine development money, all in kind of an inventory list in there. So again, not a lot necessarily in there for you directly. Kelly, anything to add to that?
I don't, not to that slide.
Okay, now fifth or sixth swim lane to all this, go to that next slide on PPP. So it added some more money for payroll protection. And, it's this time it's clear that we haven't had near the run on the banks that we had last time, and that with the lower limitation of 500 versus 300, 10 million versus 2 million in round 2, and we'll talk about more of that in just a second, it is limited. And the qualification criteria that we'll also touch on in just a second, it is very much limited to people who are applying for round 2, to where the activity has been a trickle versus the tsunami that headed toward banks last time. But nonetheless, the Rescue Act added 7.25 billion in funding toward the PPP program, but it didn't change the deadline. The deadline is still 3/31. And so if you haven't gone through the process for whether or not you've determined that you meet round 2 we very much encourage you to do that, which leads into the next slide, actually. The criteria, go to the next slide, Aaron. So as I was saying, if you got around one, and I know we covered this before, but just to beat a dead horse here, if you got around one PPP, it doesn't matter whether or not you have been forgiven, you haven't been forgiven, as long as you intend to spend it out and you're going to document round one, you are eligible for round two from that perspective. It does drop the number of employees that you can have from 500 to 300. And as I said before, you can only get up to 2 million versus 10 million last time. But the kicker has been that you have to show that you have had a revenue reduction of 25% or more in all or part of 2019 versus 2020. And there is the quarterly version of that, which is looking at gross receipts in any given quarter in 20 versus the same quarter in 19, or to being able to do it on an annual basis. I haven't talked to any of y'all that necessarily qualified on an annual basis. I have talked to several of y'all who have looked at it and either did or didn't qualify on a quarterly basis. And I've talked to a couple of you who just assumed that you didn't qualify on a quarterly basis and really did, which is part of why we wanted to beat this dead horse again, because we just really encourage everybody to make sure you go back and look at whether or not you met those rules. Now, they have clarified that the gross receipts on the quarter by quarter analysis are really all revenue all in. And so whatever you got, with the exception of your first draw PPP loan, you don't have to include that as revenue you got in 2020. And Spencer, in answer to your question, it has not been clarified to us that it has to be a calendar quarter. It is only defined as a quarter. So we're still believing that it's a rolling 12 months, that if I was you and I was trying to check in whether or not I met that requirement, it's January to March, it's February to April, it's March to May, and then go on down the line there. And if you had, I know that the input, it makes it look like it's calendar quarter, but I have not seen a clarification that says it has to be a calendar quarter, unless you have, Kelly.
No, there hasn't been specific limiting to just a calendar quarter.
So I would definitely look at it, by a rolling 3-month period through the 2020 to see if you qualify. Go to that next slide. Just to, again, beat this dead horse. If you did not apply for the first round, and you still can, again, by 3/31 this time, and forget the part about business leagues or other churches, what have you. I guess the main point of bringing this up, because I think everybody kind of went through it that thought they could last time. For the CSBs, that point about whether or not you qualify under the governmental entity that qualifies as a quote unquote hospital is still outstanding, because as I told y'all before, Robin found in the IRS code that one definition of a hospital includes community mental health centers. And ever since that time, we've been having our attorney trying to discern if they could crosswalk the law such that you could determine a hard yes or a hard no. We're obviously in the fourth quarter for that. We still don't have a definitive answer one way or the other. And I think you guys are just ultimately going to have to make a decision whether or not you apply anyway. We'll certainly send back out the documentation of the pieces that we had where we thought you guys had a case for it. But I suppose you guys just kind of have to make your own decision around that. Although we'll continue to follow up with our attorney, and if we get something definitive, we will shoot it out immediately. Next slide. These next couple of slides are really kind of pointed at the fact that there's a good broadening of what covers this. Originally it was just payroll, rent, covered mortgage interest, stuff like that. Now there's, PPP, other facility expenditures, property damage, then kind of a broad definition of essential expenses to treat COVID or to maintain current operations. and then that next slide, it's pretty broadly based that 60% of it has to be on payroll, and it's any period between 8 or 24 weeks. And the methodology for getting the dollars is the same. So it's always been 2.5 months worth of salary, but now you have all these other costs that can offset it when it's all been said and done. And so it's really, really, really geared toward becoming fully forgiven when it's all said and done for you guys. All right, so shifting out of that, once again, next swim lane, there are a couple things. The employee retention payroll tax credit, the program, I don't know how many of you guys were taking advantage of this before, but there was a program before that if you were maintaining all of your staff, then you could get payroll tax credits. And that program was originally set to expire June 30th, and now the ERC is extended through 12/31. For those that had huge reduction, 90% reduction in gross receipts, you can count all of your staff in that, and it's the limitations don't apply. You can credit a higher piece, but hopefully that doesn't apply to anybody else. Kelly, add to that. Anything else?
Yep. But Mike, I think there was a quick question back to the PPP real quick. A little more about the 500 employee level for nonprofits.
Yeah, okay. All right. If you are if you're still under round one, and I guess I'll talk about it from a 300 perspective, because this did get clarified. We had all that discussion about what's the definition of 500 employees? Was it an FTE? Was it paychecks in any given period? As it turned out, in reading the law, Morris Manning or Michelle Madison's opinion is that it's really people who own your payroll system in the first place. And so if you're a hospital and you have 300 full-time people, and then you've got some part-timers, and then you've got a PRN pool of another 200 people, which is kind of a ridiculous example, but in total there are over 500 people own your payroll system. In theory, you're supposed to not qualify right now. And the same is true if you got round one money and now it's round two, that same discussion as it relates to 300 employees applies now. And so we had talked to several of y'all that were kind of in this tweener state where I have 290 FTE conversions. My average paychecks any given period, what's 310 this time, it's 295 that time, but it kind of bounces back and forth. Can I just pick a pay period with less than 300 paychecks, and would that make me qualify? Their opinion is that if I have more than 300 on the payroll system who periodically get checks anyway, then we technically don't qualify. Richard, let me know if that answered your question. Kelly, any others?
Nope, nothing else in there.
Okay, all right, now shift to the next slide. EIDL has been, there's some more money set aside for EIDL right now. Again, though, it still has that limitation. And there's $5 being set aside for small businesses that lost more than half their revenue. But the idea, the funds themselves are limited to $10,000 per entity. So, and you had to have experienced at least a 30% reduction in gross receipts. And so I don't think that's going to apply to a whole lot of you guys one way or the other.
No.
Yes.
Only caveat to that, if you guys had applications in that weren't fully processed before funding ran out the last time, they are going to start with those that are in queue. So if any applications were outstanding, we would expect some movement on those.
Yeah. Okay, next slide real quick. They did extend the FECRA provisions, and so through 9/30. And so they also increased the eligible wages, those kinds of things, and they're effective for wages between 4/1 and 9/30, not retroactive. And so again, if you want more detail around that, we can talk about that offline. But I guess to wrap up, I wanted to talk about go next slide. A couple of things that aren't in here that we really kind of need to keep lobbying for and pushing for. number one, yeah, if y'all have seen recent emails from us, there's another push to forgive the MAP payments that were made to you guys. Again, not much of an issue for the CSBs, very large issue to the hospitals. The physician practices that are on the phone today got a little bit hosed because you got caught in this year-end thing that if you didn't pay it back, then you might have to have tax paid on it in the interim. So that really wasn't fair. But nonetheless, there's a new round of push to get the MAP forgiven. And so, but that's not in this bill that just got passed. And so we'll still need to keep lobbying for that. And I guess for everybody on the phone, our intelligence is that there's a brand new stimulus round 5 that is going to be in the works coming up in the next couple of months. And so that we would hope would be in the starting blocks for that. And, we'd follow through trying to push for that. The second one, there's the continued moratorium for Medicare sequestration. It runs out at the end of March, and it hasn't been pushed forward. And so we would have hoped that it would push at least through, the end of the national public emergency, which is no doubt is not going to end March 30th. And so, so there's that, and that 2% in theory would start coming back out of your payments for Medicare and Medicare Advantage plans beginning in April. We need to continue to push for that to stay maybe even permanently removed, but if we can't do that, at least push it on. There's no permanent expansion of the telehealth coverage and the rules around all that. And so again, to cover us from the carrier starting to mess with us on that, it sure would be helpful for that to push itself out. And then, we have heard, talk about that the HHS reporting requirements might have in some future rounds some kind of relief from people who got smaller amounts in the provider relief funds in the past, for y'all to not have to report one way or the other. And so those amounts have been previously allocated. The money's already paid for by the government. Just let us keep it without having to go through all that reporting and the potential paybacks that are going to come with all that. That no relief from that was in here, and we need to kind of continue to lobby for that if that's going to be in a future round as well. And then the last thing, as I was alluding to before, there's no additional PRF in here for urban providers. And so, yes, it's a very broad definition of what's rural, and we need to keep kind of testing the edges of that so that we can see if more and more of y'all will qualify, but there's nothing in here overtly for urban providers. Then the last one, I guess if I was trying to wrap this up, next slide. The kind of the key things that I think that if I were you, I would be thinking about, if I would consider an exchange sign up push the way we were talking 5-6 years ago, that if there's that many that have potential to move from straight self-pay to the exchange, that seems like a good deal for y'all, and whatever processes we could hook up to move from emergency room discharge or financial counselor process over to, some way to facilitate the process of the exchange sign up, that would be helpful. PPP from CSB's perspective, nailing down whether or not you qualify under the definition of a hospital, and then determining whether to apply for this round would be one thing. And then definitely for anybody that's on round 2, please go review your quarter-over-quarter revenues, rolling 3-month basis, and determine whether or not you qualify for round 2. And if you do, just know you're in the last 13 days of doing this. Not only that, but we now know that there are banks that are shutting off their applications on Friday. And so we'll have to go find a bank, or you'll have to go find a bank to work with and all that. From an HHS perspective, we check it every day, but continue checking the HHS website for updates on the reporting requirements. Nothing has come out since 1/15. It's been very quiet. The FAQ stopped, the updates, nothing has come out since then. We hope it's because they're considering some grouping of providers that aren't going to have to report one way or the other, but we don't know that. So we need to keep checking it. And then as soon as they drop a PRF, this round PRF application process for the quote unquote rural providers, we'll distribute it to everybody, and we'll need to start pulling the information together, whatever's required to start that application process from that perspective. The next one, I think we ought to continue to lobby for MAP forgiveness. Every time they bring up a bill, 30, 40, 50 Congress people jump on immediately on as co-signers onto it. And so it's a bipartisan issue at this point. And so it just seems like there would be some push to get that done. And then to continue to monitor the Medicaid expansion, both the waiver that was going through currently and whatever the state's going to do around full expansion. Again, from a hospital perspective, you're sitting on some fairly substantial percentage of your self-pay that can flip Medicaid. If from a CSB perspective, just monitoring the potential impact that can have, good and bad, from your funding streams. And I think that's all I had for right now. Anybody else got any questions? Okay. Well, I know that was a lot in 37 minutes. And so y'all holler at us if you have questions. We'll post the recording and the PowerPoint out there for everybody, but it's easier as a conversation. So if y'all do have any follow-ups you'd like to have, then let us know. Aaron, back to you.
Alrighty, Mike. Well, like Mike said, we will be posting this to our website, which is shpllc.com/webinars, hopefully later this afternoon. But again, thank you everybody for joining us today. If you do have a question that didn't get answered, you can give us a call, shoot us an email, send smoke signals, whatever works best for you. So we'll give you back a few minutes to your day. Have a great day and stay safe.
Thanks, y'all. Have a good day.